Good morning, everyone. And thank you to Dr. Seshamani for this conversation. You have a lot going on in Medicare. It's no small beat, right? There's a lot. We all know, of course, that Medicare is really in the spotlight this year because of the Inflation Reduction Act and discussions around drug price negotiation. Very, very big project. All eyes on you, Dr. Seshamani. Let's talk about that to begin with. What do you have in terms of plans right now? I know we've started hearing a lot, about where you're going to start making the plans, how the group coming together to help with this discussion is going to be formed. So fill us in. Where are we at?
Absolutely. So again, it's great to be here. It's great to be here talking with you as well, Anjalee. I think taking a step back, the Inflation Reduction Act has many pieces to it, many of which are in the Center for Medicare and will be implemented, by me and the team that I lead. And, some things have already been implemented. So, for example, there was a provision to increase payments for selected biosimilar drugs. That went live October 1st. There are inflation rebates where, if a manufacturer raises the price of certain drugs faster than inflation, then they have to pay a rebate. And the clock started for that on October 1st. And then we have provisions going into effect January 1st, 2023, that will bring real savings to people with Medicare, capping a month's supply cost of insulin that someone pays out of pocket per covered insulin product per month at $35. Recommended vaccines like the shingles vaccine will be available at no cost out of pocket. So there are some real things being implemented right now that then lead into some of the things that you were mentioning that are kind of, on the horizon. So first, there is a complete redesign to the drug benefit in Medicare. So by 2025, people with Medicare will not pay more than $2,000 out of pocket in a calendar year, which is huge to have that financial security of
Absolutely.
Knowing that there's a limit to what you could pay. And then there's the drug negotiation piece where in September of 2023, Medicare will announce the first 10 drugs for negotiation, go through a negotiation process, and that final negotiated price will be announced in 2024, which then gets incorporated into the Part D program for 2026.
That's a big project. How are you keeping track of all the parts? That's not a serious question. Looking at what you have planned, and especially that part about, capping the price, making sure that they're not raised, based on inflation. I know that that's one of the things that some are hoping actually trickles down into the commercial market. Do you see an avenue for that?
Well, the way that the rebate is calculated, so the rebate is calculated on the average, average manufacturer's price, average sales price. That incorporates commercial pricing because it's the average across all the markets. So it will look at how that price compares to what it would have been with inflation. And the calculation of that, how much needs to be paid back is then based on the number of Medicare units sold. So, if there are increases in price in the commercial market, that is one variable that gets incorporated into the whole equation that's in the Inflation Reduction Act law to ultimately determine if there's a rebate to be paid.
I'm curious. We all know that while you're sitting here planning this, the drug companies are looking at it from their angle as well. So I wonder, do you think about where the loopholes might be or where they might be able to continue raising prices even as the law dictates that they shouldn't be?
And what I will say is, before I took this job leading Medicare, I led care transformation in a major health system. I was taking care of patients. I know all too well how important it is to engage across the ecosystem where policy then meets the ground with reality. And so it is so important to me with all of the policies we do in Medicare and with the Inflation Reduction Act that we are engaging across the spectrum of everybody who is going to be impacted by implementation so that we can hear what people are thinking from their own experiences, perspectives, and expertise. So that means talking to patient groups, talking to others, people with Medicare, health plans, pharmaceutical manufacturers, biotech, academics, because we want to hear what are all the things that we need to keep in mind as we are implementing so that we can implement this law in the most thoughtful way possible.
That makes sense. When you talk about that group forming, I know you mentioned some of the stakeholders that you're talking to. I know that you've also done many roundtables and discussed with the patients themselves. What are you hearing from them?
Yeah, it's been amazing. I will say, again, having taken care of patients at the bedside and now have the privilege of leading the largest health insurance program in our country for 64 million people, it is just a true honor to be able to have such an impact on people's lives. And I think this is no exception, where in some of these roundtables, hearing from seniors about the cost of insulin. Some people have been paying up to $400 a month for their insulin, and this impacts not only them, but their communities and their family members. Because I've heard people saying, my brother can't afford his insulin, so every month I am giving him money to help him pay for his insulin, so that impacts me as well. And so where there are these opportunities where you can have an impact, now saying come January 1st, people with Medicare will not pay more than $35 of their own money for a month's supply of a covered insulin product, is hugely beneficial and really enables us to put the people that we serve at the center of everything we're doing.
I know that when you talk broadly about the system, about the health ecosystem, there's so many other players that are involved as well. You have PBMs involved, you have providers involved. So when you look at that part of it, you're the payer in this equation. Do you think that there's room for, and if you could wave a magic wand, who else would you ask to change the way that they operate?
Well, I think we all wish we had magic wands.
I'm giving you one now.
But I will say it's very much a joint effort. I think the way that I approach it is not that I want to come and say to someone else, here's what I think you need to change, because I'm coming at it from my seat at this table of the healthcare system. And I think it's equally important to hear from others, what do they think are the changes that need to be made? And that's how you drive change, right? Where there are opportunities where within the Medicare law, we can make changes in the Medicare program that can really serve to, if you will, put hot sauce or really drive forward things that have been working in the healthcare system, to take something that's worked and to expand it. Or where there's an opportunity for improvement, what's a way that we can help support that and drive that in partnership with everybody on the ground who will then take it that last mile to that person that we're serving.
I know you mentioned the volume of covered lives that you have, the biggest. That's the reason why everyone looks at what the government is doing in order to see how the rest of the market will follow and what happens there. One of the things that got recently finalized, and it's huge as a buzzword today, is mental and behavioral health and the payments for that. We saw the flexibility that took place during the pandemic for telehealth, and now we're seeing an extension of that with behavioral and mental health, which some people have coined as the pandemic after the pandemic. So tell us why that step was taken and sort of why you see that as a need for specifically this population.
Absolutely. And it comes back to something that I mentioned before. I have taken care of patients at the bedside. I have led care transformation programs, community health, case management, geriatrics, palliative care. To give an example, I led our diabetes management program. The people who were struggling the most with diabetes also tended to have behavioral health issues. If you have someone who has diabetes and you're trying to talk to them about the medications they need to take and diet and exercise, if they're depressed and they can't get out of bed in the morning, You can talk all you want about the medications they need to take, et cetera, but are you truly taking care of that person as a whole person where there are multiple things that are playing into their health? And I think that is the spirit in which we really are looking to mobilize behavioral health in our system. So you mentioned, the regulations that we recently finalized. And so there are three aspects to it. Number one, mobilizing the healthcare workforce. I think we all know that access to behavioral health is a huge issue. So you mentioned telehealth. We finalized payments for telehealth and behavioral health for after the pandemic so that you can expand access that way. We also will be paying for clinical psychologists and social workers to provide behavioral health as part of a primary care visit. Because if someone's going to see their doctor, we should take care of all of them when they're going to see their doctor and really enable that team-based approach. The second bucket is making care more effective. Again, piggybacking off of that team-based approach. Chronic pain is an area that afflicts, I think, 20% of people with Medicare that really requires that holistic view of the whole person. So we're now going to be paying a team-based payment so that you can make the care that you're providing more effective. And then the third bucket is addressing our substance use disorder crisis. So we're doing things like paying for mobile vans, for opioid treatment programs, so that you can meet people where they are to support them, especially in rural and underserved areas.
I think about the cost that goes into this when I hear about all these programs, and I think this is relevant for our audience here, the innovators. Sometimes some of these solutions that come out are very minute or step-by-step, or what they refer to as like point solutions, right? When you see the availability of services and programs for this population, are we where we need to be in terms of being able to provide everything we need to for behavioral and mental health in the country today?
I think we need to keep moving in this direction. I think being able to, you mentioned point solution, where those solutions fit into that larger picture is critical. At the end of the day, the vision for the Medicare program is to advance health equity so everyone has a fair and just opportunity to achieve their optimal health, to drive high quality whole person care, and to make the program sustainable. Innovations in behavioral health is a key piece to all of those. We know that behavioral health is definitely tied with equity in terms of access to care, in terms of other things that people are experiencing that impact their well-being. We know that if you don't address behavioral health issues along with physical health, you're not addressing the whole person, right? And we also know that we want to make sure that the money that we're spending is going towards keeping people healthy. And so where are there opportunities to examine that? And so, both for behavioral health and for innovation more broadly, seeing where innovation can address disparities in our system to really expand access to care and drive that opportunity for everyone to achieve their optimal health. Where innovations can break down the silos of traditional care so that people are seen as whole people. So you're connecting the dots among the myriad of experiences that people have that impact their health and among the various types of care that people get across settings to keep them healthy. And then where innovation can enable the dollars that are spent in healthcare to really drive better outcomes and healthier populations.
Speaking of better outcomes in populations, value-based care, really big buzzword over the last few years, and there are some really strong opinions, depending on where you are and what side of the equation you are on whether or not it's actually been impactful. Where do you stand on that now, and do you see a longer-term road ahead for programs that use value-based care?
Yeah, looking at our largest value-based care program, which is the Medicare Shared Savings Program. It has 525,000 clinicians, more than 11 million Medicare people with Medicare in the program. And that program creates accountable care organizations, right? So groups of providers come together to be held accountable for quality metrics and for financial outcomes. And over the course of this program, there have been savings every single year, most recently savings of, I think, $1 billion in one year, as well as hitting the mark on the quality metrics beyond those of providers who are not in this program. So I think that data speaks to where these kinds of holistic models can really have impact. Because that's where you're taking care of people as people. So you're going to keep them healthy, you're going to keep them out of the hospital, you're going to improve their outcomes. There is huge opportunities for us to grow participation in these models, particularly in rural and underserved areas. So we have just finalized a new program to provide advance investment payments, so upfront dollars to providers in rural and underserved areas that they can invest in infrastructure, in their teams, in addressing the social needs of the people they're taking care of. So giving that money up front to them to participate in this program, because we know from an innovation center test that that reaps dividends down the road when those populations are taken care of better. So it's an example of where we took something from the innovation center that was a test that proved to be successful, and now we're scaling it in the Medicare program. And that will help to grow the program. It also demonstrates how we want to align programs, because if you have 1,000 flowers blooming, it can be difficult to really drive change. And it also demonstrates our commitment to equity with these programs, so that we're really addressing where there are needs that the healthcare system traditionally has not been addressing.
And for those that don't know, the Innovation Center under CMS is really credited with a lot of the change that we see in the broader healthcare system and how payers behave and what gets covered. On that note, I know that you're talking about these underserved populations. That seems to be one of the biggest obstacles still. No matter when innovation comes about, no matter what is developed, it always seems like there's the coastal bias that still plays a role. Larger populations, more densely populated areas really benefit first and are targeted for use case testing. Do you think that there is value in targeting these underserved populations instead, and maybe a call to action to some of the innovators here to do some of that?
Absolutely, and I will say it is critical when we're looking at innovation to look at the impact on equity. The Department of Health and Human Services did a report analyzing telehealth utilization in 2020 among people with Medicare and found that Black and rural people with Medicare were less likely to use telehealth than their white and urban counterparts. That is a data point that we have to think about. And we really need to figure out, how do we make sure that innovation is reducing disparities and is addressing equity? And to your point, I also want to raise rural health is a key part of equity. So we have lots of work going on in rural health as well. We just finalized payments for a new type of provider, the Rural Emergency Hospital. And we sought to be as generous as possible to be able to keep doors open and keep providers serving in rural areas. We're rolling out 200 new medical training slots a year, the graduate medical education slots, targeting rural and underserved areas, because we know that where people train, they learn the needs of those communities and they're more likely to stay in practice afterwards. So to your point, I think absolutely looking at where we can drive change for rural and underserved communities will really hit the nail on the mark around equity, around whole person care, and also around sustainability for everybody.
What do you do for fun?
Well, I have 2 kids.
Oh, there you go.
So I'm actually a hockey mom.
Oh, wow.
So I spend a lot of time in ice rinks. There are not many Indians who are in ice rinks.
I was going to say, you probably stand out.
Yeah, and I think I will say to your question, whole person care also applies to each of us. And I think that is something, the team that works in Medicare is so mission driven, so smart, they know the policies, they work so hard for the 64 million people that we care for. And I always tell them, and I'm here to care for you. Like, we all have to make sure also, as we are driving change in the system, that we also are taking care of ourselves, and that is very important. So I do yoga, I spend time with my children, I enjoy a nice glass of wine with dinner. I think, and I think that's something that's very important, and that really makes you a whole person that you then bring to the work that you do. Because I think we all, especially in healthcare, because healthcare is very complex and it's very personal, and I think we all bring our full selves to our work every day. I mean, that's why people go into healthcare, because you can make such an impact on others. So it's equally important that you make an impact for yourself as well.
And ironically, the habits of physicians are worse sometimes than most normal people, right?
Oh, I did a surgical residency, so.
You know what I'm talking about. I want to end with one of the other really important projects, Medicare Advantage. That was something that was supposed to be really helpful in providing more access to care and different services to individuals with Medicare. And we've seen a little bit of, an issue with how it's rolled out, and maybe a little bit of the government being taken advantage of in this situation by the private payers. How do you hope to rectify this plan so that it returns to its original mission?
Medicare Advantage is a key part of the Medicare program. So, right, we have traditional Medicare, fee-for-service Medicare, which is, parts A and B. You have part C, Medicare Advantage, part D, prescription drugs. And Medicare Advantage is approaching 50% of the population and is a key part of the program and a key option for people with Medicare. And we must make sure that Medicare Advantage drives that vision that we've been talking about, advancing equity, expanding access to care, driving innovation so you have high quality whole person care, making sure that healthcare is affordable and sustainable for people in the program. So to that end, we put out a request for information on Medicare Advantage recently, asking questions along these lines, because we want to work, again, with everybody who is in the healthcare ecosystem, who's engaged in Medicare Advantage. What's working that we should be driving further? Where are there opportunities for improvement that we can, make change? And so we got a very robust response, not only to that request for information, but also the conversations that have occurred after that, which I think is so important as we iterate and think about how Medicare Advantage can be improved so that it is driving, these strategic pillars that we've been talking about.
Definitely. We should keep an eye on that. Have you read all of those responses yet, or were there too many?
We're going through them.
All right. Well, that really covers it for me. I want to thank Dr. Meena Seshamani for your time here and for all the insight and sharing it with our audience. Thank you so much.
Thank you for having me.